Okay, here we go. Hello, everyone. My name is Bola Oyeleye. I know the name is much longer than what you see, but most people would call me by the last four letters. I am an associate professor of nursing at the CISIC School of Nursing, University of Texas in Houston. And I'm also the assistant dean for undergraduate studies. It's a great pleasure to be speaking here this afternoon. So whatever time you have. My topic is promoting health literacy through nursing education. And it discusses the strategies and the outcomes of one of the courses that I teach. Okay, let's scroll through. So what's the background? Nurses have a very vital role in patient care. I tell my students that patients come to hospitals to see nurses. Otherwise, they'd go to the doctor's offices or the rehab centers. They come to the hospital because we're there, because it's 24-hour care. And we're usually the last bastion of defense in preventing any kind of negative or adverse results or adverse outcomes, adverse events. So it's important that we are there and that we know what we're doing. Now, in the nursing curriculum, there is no requirement for health literacy competence. There are skills and bits of knowledge that would be sprinkled in the curriculum, but there isn't any specific or any concerted or any requirement even to cover those things. And the more I have taught this course and this module, the more I realize that what I thought in the beginning is really true when I saw what my students came up with at the end of our time together. So this afternoon or at this time, during this period, I hope that you'll develop an understanding of what nurses know, especially nurses that have either more recently acquired their associate degree or some that have practiced for a while. We have a combination in our program, and you will find out strategies to improve health literacy abilities for nurses and other healthcare professionals. And as I discuss or mention the materials that were used for this module, you would become familiar with them. And I'm hoping that educators and clinicians will be able to replicate this type of curriculum or module in your particular facility. What was the purpose of this instruction? We wanted to create an awareness of health literacy in the clinical environment. And again, as I go on, you'll realize how needed it was. We wanted to enhance recognition, response of our patients, of our students to be aware of the patient's health literacy status. We wanted them to respond to cases and scenarios that put them in the driver's seat, as it were, simulations of if this were happening, what would you do? What do you see? And then we also wanted them to develop or express a personal commitment to taking health literacy into consideration during interactions with patients. What we just found out was we could teach, but if they didn't personalize it and actually visualize themselves using the strategies that we teach them, it would make really no sense. So what did we do? What's the medium? This is an RN2 BSN program, and the course is usually the second course in their progression, and it's online. So some of the things that we did in there, like the discussions, you would see that it made sense because they do not sit face-to-face in class. So what did we do? There was a PowerPoint lecture on health literacy that we provided, videos and documents of scenarios of health literacy-based situations. We then required the students to discuss in smaller groups their reactions to the module resources. So you've heard this, you've heard the lecture, you've watched the scenarios. Now tell us more, like eliciting not just cognitive benefits, but their affective benefits also. We then wanted them, each of them, to individually reflect on low health literacy indicators that they have experienced or that they have seen. And what we found out was that as many of them mislabeled the health literacy or low health literacy symptoms that they were seeing. They thought it was something else entirely. But the information from this course allowed them to say, oh my goodness, I totally missed that, or I misjudged this person, or I didn't understand what was going on. And then we wanted them to also make a commitment to becoming mindful of and of low health literacy and addressing it in clinical interactions. So the strategies and outcomes were as follows. We had 52 students over several semesters. And one of the things, like the resources we did, once they had viewed those resources, we then asked them questions. And one of the things we asked was, what have you noticed or what have you learned through the module that would suggest your patients may have a difficult time understanding? So we wanted them to think about the factors that would point them in the direction that a patient may be experiencing or may be having a difficult time understanding. Then we wanted them to think about the specific patients that they saw in the videos. What surprised you about their attitudes, their concerns, or questions? And I will discuss, the answers to these questions as I move on. The other question we asked was, what surprised you about your own knowledge, our attitudes about health literacy and patients? And then we wanted to know what they had learned and how they would use it to improve their communication with patients and how they will change their practice to accommodate health literacy, patients' health literacy levels. So these are all questions they answered either individually or as part of a discussion group. So the first one was, what have you noticed or learned through the module that would suggest your patients may have a difficult time understanding? So these were things that most of them said before they really didn't attribute to low health literacy. That some of them felt that when a patient, now they know that when a patient does not ask questions, it could indicate that they really didn't understand what you said. Or if the questions are not quite as related to the matter at hand. But usually now they're thinking, if a patient is just nodding and not asking questions and possibly even smiling, that it may mean that they don't understand. And some of them realize that now they know that when a patient leaves registration forms unfilled, or they say, I'll take it home and I'll bring it back, it may indicate low health literacy. The patient's body language, also they're realizing now, may indicate low health literacy. Are they sometimes excessively nodding? That may mean they don't quite get you, or the other way where they're pulled back. Their medication usage and adherence, they now realize that, and some of these also, they told us they mislabeled. When someone comes and you're saying, did you use your medication? And they say, well, no. It may just mean that they don't know how to use it. Or if they're using it in a way that's different from how it was prescribed. One of the videos they watched was where a patient was using their medication 11 times because once means 11 to them in Spanish and it was written in English. So once is what they were supposed to do. So they're realizing now that adherence could mean that, or lack of it could mean low health literacy. If there's post-care follow-up that's not also followed up, if you're supposed to come back and they don't, it may be that that whole clinical encounter was confusing to them. And they now know that if someone's of a language minority, it's important not just to call an interpreter, which many hospitals do, but to also make sure that whatever it is, whatever language an interpreter is using, or whatever language they're using, that it's also not, that it's appropriate. But these were things that they figured out, okay, going forward, if I see any of these things, it's going to alert me to the fact that the patient may have low health literacy. Our next question was, what surprising information did you encounter? from the module resources. Now, many of them, and this was surprising somewhat to us too, patients' difficulty with medication. They were surprised that the things that they had been taking for granted, that I have said it, I've described it the way I'm supposed to, I've used literature, I've done all that. Well, they should not be having difficulty. And then they watched these videos and they realized, this is surprising. They didn't think that. Many of them said, I look back to many patients that I had talked to, and I'm sitting there now going, I did not do right by those people. So this was a good outcome for the course, because they're realizing where they went wrong. The other thing was they were surprised that patients, even though we teach them about informed consent, we teach them what they need to know about informed consent, many of them still feel that if the patient signs it, they must understand it. So they were quite surprised that the signature is only an indication that they were there and they heard you. It didn't mean they understood. So that was surprising to them. It was also surprising to them that clinical information, which healthcare professionals, even first semester nursing students, we learn this language very quickly and then we start using it, thinking everybody understands. And they're realizing that a lot of the words they've been using are difficult. Written information was another thing. A lot of them prided themselves in, I always give my patients written information so they can, understand what it is. And they suddenly realized, they were surprised by the fact that it's not important, it's not enough to give written information if the person you're giving it to does not read at that level or doesn't read at all. So those are the things that surprised them, that all the things they'd been doing that they felt they were doing correctly, there were actually gaps in those, and that it wasn't really benefiting their patients as much as they thought. So we wanted to know what surprised them about their own knowledge and attitudes about health literacy, because now they've seen all these videos, they've watched they've heard the PowerPoint, and now, because it's important for us to assess ourselves, reflect and see where we are, our attitudes, our biases, to be able to move forward. So we wanted them to look at themselves critically. This is who I was before I came into this course, and oops, I'm surprised that, that's really not how I'm supposed to be. So that was a question we asked them, and this is what they said. They were surprised by their own lack of knowledge or limited knowledge relating to these things. They were related to the reasons for patients not adherence to treatment regimen. Some of them said they totally judged patients. If you're supposed to use this medication and it's for your good, why don't you use it? You must not care. And now they're realizing, really, it was they didn't have as much information. The potential embarrassment about low literacy skills. They were surprised also that there were people who would, because of embarrassment about their literacy levels, would act like they can read, or would just not ask any questions and just say, I'll go watch YouTube videos at home. So that part they felt they didn't know that existed. Limitations of written clinical information. I alluded to that earlier. They just felt that they were really doing a top-notch job if I've explained it and I've given them stuff to read at home. And they're realizing that that's actually also limited. The impact of not using qualified interpreters. They also realized that when children or family members interpreted, they didn't realize how much of a damage that it could do to the patient and their outcomes. They were also, as I said earlier, signing of informed consent forms. They didn't realize that the fact that the patient signed it does not mean they understood it. And this came out of a video of a patient who had a hysterectomy and did sign the consent forms, but didn't know what they had signed until they came back for the post-surgery care. So this was quite a shock to the students. They were also surprised at their own lack of knowledge about patients' comprehension of medication instructions, which, some of the stuff I'd said earlier, that surprised them too. They didn't realize how different the patient's perspective was from what they had thought. They also didn't realize the impact of being of a limited English proficiency. One of the students said, I work in a predominantly Spanish area and I've learned a few statements and words in Spanish. And after this module, I'm realizing that that was not enough to do all the things that I needed to do for my patient, because I had gaps and I only used specific words that I knew. And now I'm realizing that I really ought to have called an interpreter. So we wanted them to now say, what have you learned that you will use to improve your nursing practice? So here we come from, we've provided the knowledge, we've asked them to analyze those things we've taught them. We've asked them to reflect on who they were before they came to the module. Now you've seen all of that. What would you now do? What's the new knowledge that you have to improve your specific nursing practice? This came into three major segments. Information dissemination. They would avoid giving a lot of information at the same time. They now realize that can be, even for the best person who understands everything you're saying, that can be information overload, and that would lead to pretty much low negative outcomes. They would, in the same vein, limit information to 3 to 5 key points at a time. And some of the students said they will reassess to make sure that their patients understood what they were saying. The reassessment, in our discussions with them, we would discuss how they would do it, because when they said they'll reassess, that was part of their discussion, but we wanted them to give details, because sometimes you reassess with big clinical terms and your reassessment doesn't help. If your reassessment is something like, do you understand? The patient's likely to say yes. So it's important that they actually also reassess strategically. The other aspect of it also was that they would, in personalized care, they will find out what patients already know and continue from there. Because a lot of them just assumed that patients knew, either based on how their patients were dressed, believe it or not, that if the patient is dressed well and they look like they're educated, I assume they know, but they're realizing now that they need to actually figure out what the patient knows. They will give specific and concrete information that pertain to that patient. Some of them realized that they were being general, and they would avoid generalizations and show empathy. For some of those who felt like they were very judgmental about people who did not adhere to medication, who did not adhere to follow-up care, who didn't look like they cared, that now they understand that some of those things might be because of low health literacy. They would show more empathy. And the strategies to ensure comprehension, which is what I was alluding to under reassess. They will use plain language. And throughout the course, we had them then recheck the language that we're using to say, can you use an easier, a simpler word, a less technical word? So they will implement the teach back method. Every single one of them actually said this, that we will use the teach back method, because many of them said, I would just say, do you understand? And they would say yes, and they used to move along. And now they no longer would do that. They would also use open-ended questions, because they will teach them that in nursing school. And somehow, I guess it falls by the wayside. But for this particular demographic, they said they would use open-ended questions. And a lot of them said they would seek systemic change. And by saying that, they would have their their CNOs and their supervisors have nurses in their unit engage in health literacy knowledge, and have possibly a champion in the unit that ensures that every patient that walks out of that place understands what's going on. So what are the implications for nursing practice? We should include health literacy related content in nursing curriculum. I am more convinced than ever that we will do the best for our patients if we just recognize where they are and put ourselves there. And the more students come through this module, every single reflection leads me to realize that this is something that we should do. We should encourage students to reflect on their own practice, which is sort of what we did here, beyond the clinical skills. Many of them thought they were coming to nursing school and they were going to RN to BSN school and they would do a lot more clinical stuff, like skills, but they're realizing that there's a lot beyond skills. And then we should also encourage students to reimagine their nursing practice with their patient's health literacy status in mind. Not just learn the things, but say, this is who I am going to be based on all these things that I know. So that's the sum and total of it. And I will pause now and see if there are questions. Okay, if there's a question there, I don't see it. Is there a question that I'm not seeing? Okay. What's about how was the training done? Yes. The training was done on, the training was done online. It's the RN to BSN program in our school is predominantly online. So they have like 50 hours in another course that they have to do face-to-face, but this is an online RN to BSN program. Okay, while we're waiting for those, my area of scholarship is with special population. Okay, how many hours? The course is a 4-credit course. And 1 week, 2 weeks is this module is 2 weeks. So we program enough work, face-to-face, like contact work, 4 hours each week, including discussions, including the videos, including all those things. And then the second week also, we allow them to discuss and reorientate their minds in the things they're doing. So really it's online and it's one of many modules. And I was about to say that my area of scholarship is special populations. So I have modules on disabilities, caring for people with disabilities. I have modules on culturally and linguistically appropriate care. So that package focuses on special populations. So this is one of those. There are 6 weeks altogether that I devote to those topics, 2 weeks each. Okay, difference I've seen adoption of my. Okay, let me see. The cues somebody would give in a visit when they're not actually understanding what you're saying. Some of those cues are that they would actually over nod, because then you should be realizing there's not much I'm saying, or they would not ask any questions. Or you give them forms to sign and they say, I'll take it home. That means, okay, there's a literacy issue here. And sometimes the body language is they're pulled back and you're talking and their eyes just are not there with you. And as I said earlier, they're not nodding at the appropriate points. Some of those things might indicate that they're not understanding you. Differences that I've seen in the adoption of my learning objectives among nurses of different backgrounds and ages. Any differences between newly minted nurses and those who have been in the field for a while? Frankly, every one of those, you see, they're coming from nursing school and they're all thinking like nurses. The only difference that I think I have noticed, and it came in probably another module, is that students who are linguistic minorities had stories to share about family members who went into clinical environments and did not quite understand. They shared stories about how they were required to interpret for family members. But when it came to they themselves as nurses, they had the same type of stories to share about how they didn't understand some of the pointers to low health literacy. So they could understand experiences from their own lives in one box, but they themselves went into the clinical environment and didn't quite understand from another person's perspective. So, and then differences between newly minted nurses and those, no, not really, not really. As I said earlier, you see, there is no requirement for health literacy content at, in the nursing curriculum. So whatever they learned in school is what they were practicing with. And so the best of them went into the clinical environment thinking, I'm going to give them stuff to read. I'm going to ask them if they understand. That's the best they knew. But once they got introduced to this content, that they realized that even the most experienced of them, who was patting themselves on the back for, being really good, was realizing that that was actually, not enough. Which is why some of them said they would seek systemic change, because it's not enough to just hand people medications and then they go home and then they take them wrongly because we didn't take enough time. And then they have to come back for admission, for surgery, because we just didn't take time to make sure that they knew what they were doing before they left us. So each one of them actually did recognize that they were missing something. Okay, let's see what I'm missing. Open questions, I think. How many hours done? Is there a fee for the course? No. This course is a part of a nursing curriculum. This is for RN to BSN students. In my school, you could go 3 semesters, 2 semesters, 3 semesters, or 5 semesters. So this is one of the courses, and it's actually one of the modules in a course. So it's not billed separately. Differences in the adoption. Okay. Okay, I think, okay, does a course offer participants a way tools to self-monitor their long-term learning post the course? No. The reason that this is like their second course and then they keep going, there are probably 5 or 6 more courses after this. I am hoping, well, we're hoping that the question where they started to reimagine themselves in the clinical environment, and when they're saying, this is what I will do differently, allows them to at least think about it before they get there. That way, but no, once they leave, they really don't come back to these courses. So that's really the short answer to that. To other healthcare organizations. To be honest, there are 3 courses on my list that I keep threatening every semester to finish, to develop it, and then to start offering it to, first of all, to our faculty, and then to other health organizations. And every time I think I have enough time to do that, something else comes on, but not at this time, but it's in my head somewhere to develop this course and be able to offer it to in our school and then to people in the Texas Medical Center. But yes, thank you for the question. I'll be thinking about it more. And thank you. Okay, I think that's been answered. And I've answered that too, so. All right, let me see. Yes, we have 1 minute to the end of this, and I want to thank you very much. Again, my name is Bola Oyeleye. I am an associate professor of nursing at CISIC School of Nursing and the assistant dean for undergraduate studies. My suggestion for ongoing self-evaluation, that is effectiveness, after completion of the course, my suggestion, really, I would suggest to them to, after every patient encounter, when there's something we call the nurse's brain. It's part of, you write things down so that you don't forget. And it's one thing I would ask my students or everyone who takes this course to, like during discharge planning, make sure that you have an asterisk there somewhere that puts HL somewhere. Every time you write something, every encounter with a patient, put HL in the corner somewhere to remind yourself that you have checked off all the things that you say you will. And in that case, hopefully they keep remembering. But if they have a piece of paper, we tell every nurse to write down, to put down so they can remember things. If they put HL on it too, they will be able to to reflect and self-regulate in this area. So we are at 3:15. I want to thank you all for attending my presentation. Take care and have a good rest of your day.